welcome everyone here this evening and joining our evening lecture entitled Marching Through the Madness, the Game Plan for Your Refractive Surgery Patients by Dr. Bobby Sines. I'm your host, Dr. Carolyn Major. And we want to give a special shout out to our sponsor here this evening. We could not offer free CE without them. So thank you, Zeiss, very, very much for exhibiting at this event and for your sponsorship of this lecture. Just a few reminders and housekeeping items before we get started. For each hour of CE credit, you have to be online for a minimum of 15 minutes. And for COPE certificate, you need to fill out a survey link that will be at the end of the webinar. That link will be in the chat, and that survey is also going to appear and pop up as soon as the webinar ends. CE certificates will be delivered by email and sent to ARBO with OE tracker numbers. We'll also display a QR code at the end of the event. So if you have the OE Tracker app, you can't just use the camera on your phone. You have to actually have the OE Tracker app downloaded on your phone. You'll be able to snap the QR code and immediately upload it to your profile. CE certificates will be emailed within 4 weeks. And we're going to have a live Q&A at the very end of the session. So if you have any questions along the way, please use that Zoom on-screen floating panel to put in your Q&A questions so that we can get to them at the end. If you're joining us on your phone mobily, you can also ask questions using the little Q&A box up at the top or the 3 dots in the bottom right-hand view of your Zoom screen. And without further ado, I want to welcome our speaker here this evening. We're so fortunate to have him. Roberto Bobby Sines graduated summa cum laude with a dual OD-MS degree from the University of Houston College of Optometry. He then completed a residency in refractive surgery and ocular disease at the Eye Center of Texas. And Dr. Sines is passionate about service, has participated in many medical mission trips, and teaches nationally and internationally on ocular disease and ocular surgery. He recently helped found the Mission Cataract and LASIK in San Antonio, Texas area. He's also an adjunct assistant clinical professor at the University of the Incarnate Word Rosenberg School of Optometry, where he leads both the glaucoma and the posterior segment 2 disease courses. So welcome, Dr. Sines.
Thanks so much for having me. I'm going to go ahead and share my screen here so we can get started. Well, thanks everybody for having me. And it's really interesting. The last 2 CEs at SECO and now, I feel like I'm losing my voice here for some reason. And I think if you have kids and you can relate to them just going back to school and getting their stuff, it's just, man, it's one of those seasons. But welcome to the madness, right? It is March Madness time. We're looking at the score right now, 60-62. St. Francis and Alabama State. The first March Madness game is going on. And if you're not into that game, rest assured North Carolina and San Diego State play. But we will be done by this with this CE, hopefully, right as that starts. So we're going to be talking about refractive surgery today. And here are my disclosures here. It's just interesting to think about refractive surgery, and probably the most common refractive surgery still done right now is cataract surgery. And it's interesting to think about how cataract surgery and refractive surgery has really changed over the years. I mean, you think about this like gouging, the first form of cataract surgery where it's like needle to the eye. Let's just put that in the vitreous so you can see clear and wear plus 15 glasses. But it's really crazy just to think about how much surgery has changed. 5 years after the microwave, or 5 years after the first lens was implanted for cataract surgery, we get the microwave oven. Around came around the year MRIs came out, 1973. When DVDs came out in 1996, you had toric IOLs and multifocal IOLs. And we're just going to talk about just this evolution of how refractive surgery has changed. I like to even just think about myself, there as a 5-year-old, they called me Windows 95 because I was missing my front 4 teeth. And then when COVID hit, it was really great because my license was up for renewal. So my picture on the left there, that's what I looked like for a long while. And I'd go to the airport looking like this, and they'd be like, "This, you got to update your ID." Finally, I had to change my driver's license. So just like I've had changes, surgery has had changes, and we are going to go through those and really talk about the role of optometry. If you have here this first review of optometry article where co-management was discussed, I love that, in 1984. And it's always been cool to show this picture at presentations, and some people come up being like, "Oh, I know this person. I know this person." It's really great. There's just been so much change, even over like the past 5 years, and we're going to be talking about that. And we're going to be talking about the different types of quote unquote refractive surgery, whether that be cataract, refractive. Those are the main two that we're going to be focusing on today. And the thing that's getting interesting about cataract surgery is there's more and more ways that we can correct the vision at the same time. And with the amount of surgery increasing, optometrists, one of the surgeons, we'll talk a little bit about the practice that I'm in now, but one of the surgeons, he said it was like almost somewhere between 43 and 48% of the American Academy of Ophthalmology members, which generally represents like 98% of ophthalmology, is over the age of 60. And it's like, gosh, if that's the case, like we're gonna have to step up to the plate because the number of patients who are growing and getting cataract surgery is increasing. And so optometrists, like, we're gonna have to step up. We know about these patients' vision expectations, like, a patient who comes over who's nearsighted and wants to fix their far vision, whether that be with LASIK at 48 or cataract surgery. You might have fit them in contact lenses and single vision distance because that's what they thought they wanted, and it was like, that's a bad idea. We got to use that. We got to talk together. We got to use that for the good of all involved. And so I like to first start off with cataract surgery and just making sure we kind of review what's available. And if I like to break it up into, let's call it four buckets. First, we have monofocal or toric monofocal buckets. That historically has been we just correct one vision zone. What's growing right now is accommodating IOLs. That's the holy grail. If that comes out, awesome. We have this spaceship looking IOLs that are finished enrolling in clinical trials, being submitted to the FDA. There's some stuff coming down the pipeline. Even Alcon has a lens that's in clinical trials right now for accommodating IOLs. So, that's the holy grail. If that comes out, great. But right now, not really anything that we're doing there. What's really came out is the extended depth of focus lenses and the enhanced monofocal lenses. And the extended depth of focus lens, in order to meet that qualification, you have to basically have about 1.5 diopters of add. And so that comes in, Symphony, Vivity comes in that. You even have this pinhole IOL, which is the Apthera lens here, which causes the extended depth of focus. So those lenses are nice because it gives distance and some middle range of vision. But anytime you're stretching out the light, you can possibly degrade some of the distance vision. And so extended depth of focus lenses have a role, being able to get some distance and some middle vision. Now, for the lenses that are somewhere between the monofocal and the extended depth of focus, you have these enhanced monofocal lenses. So this is for somebody who wants distance, some middle vision. Like, for example, the iHance, you have that available. Bausch and Lomb, you have the Invista Aspire. Those lenses probably give somewhere around 1.3 diopters of that. And so those are kind of nice because they don't get the 1.5, get distance, get some middle vision. So when you're walking around, you can see the floor. Those patients still need reading glasses. But that population is growing a lot. There's more and more patients who are picking these lenses. And even sometimes with smaller pupils, these patients are able to gain even more vision. Now, the benefit of that is that you're able to get some middle vision. We don't want to overset the expectations. Uh, they're able to gain some up close vision without having to go to a multifocal. Now, the multifocal, so if we have bucket one monofocals, bucket two, let's call it enhanced monofocal, distance and a little bit of intermediate, extended depth of focus, distance intermediate, maybe a little bit near, 1.5 diopters of add. Then you get trifocals, which give distance intermediate and up close. And the Panoptix has been the biggest lens that's come out, that's been around for, since Labor Day of 2019. My mom got that the first day it came out. But now you have Bausch and Lomb coming out with Envy, J&J coming out with Odyssey, trifocal lenses, distance intermediate and up close. Now, the way that they're able to do that is they have circles on the lenses, so you get distance, middle, up close vision, better 20/25 or better at distance intermediate and near. It gives a really great functional range of vision. But for those that are wanting 20/15 at all distances, not a great lens for them. And also, you're going to have circles on the lights at night, which gets better on time. Now, the other kind of lens in this category is the light adjustable lens. Now, the light adjustable lens is somewhere in between the enhanced monofocal and the extended depth of focus. I think it probably gives around 1.1 to 1.3. Now they have the light adjustable lens, that's the plus. And just from my own personal experience, that gives about like 1.3 diopters. And we'll talk about that in just a little bit. But the benefit of the light adjustable lens is you have the ability to adjust it, right? If somebody wants far vision and maybe monovision, you can give them that. If somebody wants distance and blended vision, you can give them that. or in our post-refractive patients, it can be really helpful. So it's all about knowing kind of what the normal results are, because then that helps us really set the expectations. So for example, my mom got the trifocal. She was a plus 350 hyper. She got that the first day it came out. Great, happy, awesome. She probably would have got a monofocal and been happy, but she got trifocal. She can see 20/20 distance, 20/20 up close, loves it. She had circles on the lights at night for about 3 weeks and then they went away. I don't tell anybody that. I tell people it's going to take 6 to 9 months to get better. My dad, retired police officer, he wants to see craters on the moon at night. We didn't let him get it. Like, we were like, no, this is just not a great idea to get it. You have too high of expectations. Well, eventually he was wearing progressive glasses, takes a step off the ladder, had that kind of swimming vision, steps, hurts his shoulder really bad. And he's like, you know what? I'm fine. I'm like, Dad, you're gonna have 20/30 distance vision, 20/30 near vision. He's like, I'll live with it. Okay, great. And he's seeing better than that at distance and up close. Usually on these trifocal lenses, whichever surgeon you're sending to, they usually have just kind of like with contact lenses, you have your one that's like your go-to lens. And Envy and Odyssey have come out more recently, so surgeons are playing around with that more and more to see which one they like the best. But now it really gives us options for when these patients who chose refractive surgery. So we take a look at this patient who had hyperopic LASIK, and you have this circular pattern. So maybe you're like, I don't want to do a trifocal because the trifocals have circles. This really gives us, like, these patients can be really difficult. These post-refractive patients, they have really high expectations. It can cause a lot of madness. So how do we march through it? Well, now with the enhanced monofocals, the extended depth of focus lenses, and really the light adjustable lens, this gives us the ability to correct for these patients' vision. Because with people who have had a history of LASIK, you go into cataract surgery and you're like, oh gosh, where are the calculations? What was their prescription beforehand, after? What were their Ks before or after? And if you don't have that information, how do you pick the lens? Well, it's great because if you look at, depending on what study you look at, if 15%, 50% of these patients are within half a diopter, no big deal. We have the light adjustable lens. We can use the light to adjust them. Now, if they have a goofy looking cornea, so for example, down here you have this decentered myopic ablation. This is the eye trace. And what's nice about the eye trace is you can actually split up. And if any of you guys have the Pentacam XL Wave, you can do this too as well. This is what looks like the E looks like with the cornea on this decentered myopic ablation. So what happens is you can actually make the pupil smaller and smaller and smaller. And as you make the pupil smaller and smaller and smaller, you see the image quality gets better. So you could come over here and use the pinhole IOL, the IC8 or Apthera lens, and potentially make that pupil smaller and give a better quality of vision. So this can help in patients who have a goofy cornea or somebody who wants to extend their depth of focus and minimize their chance for circles on the lights at night. So, with regards to these extended depth of focus lenses and even the enhanced lenses, enhanced monofocals, what we're seeing is you can either do that by making the pupil size smaller, or what you're going to hear a lot of coming out, and I think you're going to hear this over the next 5 years within cataract surgery, and I think even enhanced monofocal lenses will become the standard of care eventually. Once we can get the insurance to cover it and reimbursement and the lens costs, that's still got to come, is by manipulating the spherical aberrations. And what happens is if you don't have spherical aberrations, if you look in this top left picture here, you'll see that's the eye chart at distance, great. And you look at 1.5, you really can't see any of these like bottom letters. Now, if you come over here to 0 with spherical aberrations, now just a little bit of spherical aberrations, you can't put too much or that will really start to degrade the vision. But check this out, okay? So the vision quality, like, is it as good? I mean, no, it's not perfect, but you can still make out KDNVO. And now you come over here and maybe you can't make out that KDNVO, but you can make out the VOD something K. So you just get a little bit more up close vision. And so it's all about balancing this. Like, how can you give somebody I mean, everybody loves to see at distance and up close. And like, you always have patients who have cataract surgery and you're like, oh man, I wish I would have picked the other one. Like, of course, right? So if we can give patients the most amount of range of vision with minimizing dysphotopsias, I mean, that would ultimately be the goal. And the fact is, we can't do that perfectly. So we have to just set the expectations with what we have. Now, what's nice about this, though, is instead of doing monovision, one eye for distance, one eye for up close, now we get eyes that get distance intermediate. So the other eye, you can do a little bit of an offset. And you think about somebody who has a 1.3 diopter or 1.5 diopter add in that built in their cataract surgery lens. Well, you can just offset it like minus 75. And now you got 225 add effectively. Now that's pretty functional. And so you get more of this blend zone, the more of the eyes working together. And so we typically have happier patients as long as we can set expectations appropriately. Now, with the trifocal, it works great. You have patients who are 20/20 distance, 20/25. I always say in the clinical trial, it was 20/25 distance, 20/25 near, just again to set the expectations lower, even though that was average. And you had people who are 20/15 distance, 20/15 up close, right? But you have to just basically tell patients, you're getting this range of vision, this blended vision. It's a great range of vision lens. It's not a perfection lens. So with if somebody was like, for example, who came in, I had a patient who came in, he's been an emmetrope his whole life. He came in, he was on the refractive lens exchange kind of cataract surgery side. And he's like, Bobby, I want to be able to see a billy goat 500 yards away when I'm like shooting. And of course, everybody in Texas, right, comes in for their cataract eval. It's like, oh yeah, shoot. And we have to work through scope or like, well, we have to march through that. But regardless. And you got to figure out how much they actually shoot. All these grandmas say they shoot, but then it's like, okay, well, it's like once a year or like every single day. Anyways, so this guy comes in and he says, yeah, I want to be able to see a billy goat 500 yards away. I'm in some fancy rifle club. Great. So for him, just doing cataract surgery with a basic lens, not correcting astigmatism, he would not be happy. Even maybe use a laser or you're correcting his astigmatism. He had like 0.75 sil. So we actually used the laser to correct his 0.75 sil, and he was left with a quarter. He was plus a quarter, minus a quarter, and came out 20/25. For him, we used the light adjustable lens. And he was like 20/25 after, I mean, we could have pushed him to 20/20, but he was 20/25. And I was just like, well, good thing we use a light adjustable lens. We'll be able to tweak this. He's like, thank God, I could not live with this vision. And it's like, okay, come on. So light adjustable lens is just good for really like dominant people or people, you want to just be able to adjust afterwards. And he ended up great. He could see, he was able to get 20/15, and that's what he's always been able to see. His other eye didn't really have much of a cataract, was still 20/15. And he was okay wearing reading glasses for distance. He really wanted to nail the distance vision. So I think when, we see these patients who come in either for cataract surgery or our over 50 crowd coming in for LASIK, and we're considering more of refractive lens exchange, it's really just important to understand, do they drive? Do they shoot? Do they knit? Are they on a computer with 3 screens, 2 screens? I had a patient who came in. She's about, let's call her 50-year-old, plus 350 hyperope. And we know plus 350 hyperope LASIK, like it's just not going to work as well. So we were talking about doing the lens treatment, but she is DEA, law enforcement, and like does stuff at night. She's like, I don't normally work at night unless we have to do some kind of raid. I'm like, okay. So like, how do you pick a lens for this patient? How do we set expectations? She had been wearing contact lenses and she just had dryness with her contact lenses. It had been rotating some. And she was like, man, I'm interested in doing surgery because I want to see better. So do you give her a trifocal lens that gives distance, middle, and up close, but then she has circles at night? What if she gets in a shootout at night? Do we give her distance, middle? Like she'll do great with that, except then long term, she's going to want to wear reading glasses her whole life. Like these are the conversations that we're having with patients. And it's all about setting expectations. Because if you can set expectations well, and patients know, what I say, happiness equals expectations, results minus expectations. We know what our results are. So the question is just like, how confidently can we set our expectations? And are you or the group that you're sending to, do they have enough time to set the expectations properly? Now, one thing that's really interesting, and I love this study, it came out in JCRS in 2017. This actually talks about patients who have trifocal lenses or multifocal lenses. And what happens is after surgery, 1 day, 1 week, 1 month, the patients are going to come in complaining of halos. And they actually did functional MRI studies because if you work in a surgical setting, what you see is that patients are like really, I'd say some patients are really annoyed, some patients are like meh, and some patients don't see it. But the patients who are really annoyed, they come in and tell you at the 1 day, the 1 week, the 1 month, they're telling you all over and over again. But then when you get to the 6 month visit, some of these patients are like, why am I even here? And you're like, I was just going to check on you to make sure your circle, so at night we're doing good. But they're like, yeah, I'm doing fine. Okay, great. See ya. So neuroadaptation is a thing. Like there's some people who don't believe in it, but like there's actual studies that show us with the functional MRI, connections between the frontal and parietal lobe after multifocal light up. Like it is lighting up. And then you do that same functional MRI at 6 months later, not as much lighting up. So neuroadaptation is the thing. We have to encourage our patients, with time, things typically get better. But then again, like again, the better you set the expectations on the front end, like, hey, you're going to see these for 6 to 9 months. The brain's going to continue to adapt to it. Great. If they adapt to it at three weeks, great. If they come in telling you at 1 day, 1 week, 1 month, we say, yeah, remember we talked about that, and things usually get better. So one other case I thought would be interesting to go through was a patient who came in for a LASIK consult, and we see what happened with him is that he has what condition here? He has inferior steepening. You're like, "What, Bobby, actually, that's inferior flattening." Yeah, well, way down below, he has inferior steepening. You see down here, inferior steepening, and then he has posterior float way down below. So he actually has pellucid marginal degeneration. So he came in, he wore contacts, he wore glasses. He was just like it just wasn't working for him. So what we talked about, because he used to wear blended vision with his contact lenses, we talked about doing blended vision with a light adjustable lens. And so that's what we ended up doing was blended vision. And he came in and he was doing really well. We were able to tweak him, offset him just a little bit, like by plano in one eye and like -50 in the other eye. And he did really, really well. So, with regards to these patients who are coming in with cataract surgery or even refractive lens exchange, again, it's all about we got to know who the patient is, how are they wired. Like I remember as a student, the first patient I ever sent for cataract surgery, I was so happy. I made the diagnosis of a cataract. They were 20/80. Life was great. I sent them. They came back. They were 20/20 uncorrected. Great. Except they came back so mad. Like I thought we were going to do high fives and cartwheels, and they came back so mad. And I was like, what is going on? Why are they mad? Well, she was a -3 mile before surgery and could sit in bed and read her Bible. And then after surgery, they just corrected her for plano. And boy, was she mad. And her daughter was trying to calm her down. I was like, oh my gosh, this is so awkward. And so I think, with regards, it's communication is really important. If we go back even to the beginning, like if optometry and ophthalmology are going to be working this close together, like we have to know, like what lens did they pick? How was the patient wired beforehand? What expectations were set so that we feel confident going into the room and reaffirming the patient, right? How many patients have we seen for cataract surgery post-op who are like 2015? And they're like, am I doing okay? And you're like, yeah, you're crushing it, right? It's all about reaffirming the patient, but also we got to know, what they picked and why did they pick it? So we can make sure that we continue to set the expectations like in everything else that we do. So it's kind of interesting. If you were having cataract surgery tomorrow, what lens would you pick? Now, let's talk about question here. All right. So one question that came in was, talking about trifocals and age-related meiosis. It's really interesting with uh, if you look at like this, yes, that definitely you should take pupil size into consideration. But if you look at most of the FDA clinical data that's submitted at 6 weeks, they stratify the groups based on pupil size, and typically the group that's doing the best is usually the one with the smallest pupil. Now, what happens though is you have to be, careful. Because yeah, if you have too small of a pupil, then we get limited by diffraction and other things in life. So yeah, of course, but those patients typically like have the small pupils give them an extended depth of focus. So I think it's interesting with cataract surgery and overall with just refractive lens exchange. These patients who are coming in hyperopes over the age of 50, we have a lot better options for giving them a range of vision. And I mean, you can decide, right? There's some people who really pick like trifocals. There's other people who are like, I just don't do trifocals. I don't do multifocals. So I'm going to do extended depth of focus, enhanced monofocals, blend them. Great. There are multiple ways that we can correct patients' vision. All right. So next up here, we're about halfway through. I like to just, man, it's crazy just to think about like for me, when I first got a phone, I was in the Nokia 3210 group. I was really excited to play Snake in seventh grade. So pumped about that. I only had like 15 minutes a month, so I had to make my phone calls quick and didn't have text messaging. It's just interesting to see the evolution. And I think the same way, I think if we think about this is a few years ago when we went to Orlando. There's Bella and Sophia hanging out. Great. Uh, like this just summarized our household. My wife just like so prepared, like had umbrellas. I didn't even know it was gonna rain. That explains our household. And then Sophia was like, "Nah, I'm good. I don't need the umbrella, so I'm just gonna hang out." But let's say we walked, we slipped, and we fell, and we broke our leg. And they were like, "Bobby, you can wear this external fixator device, or you can have surgery. What would we pick?" And I think a lot of us would pick if we had a broken leg, like let's pick surgery. And the thing is like it's interesting when we think about like our eyes and being nearsighted. I think oftentimes we think about surgery instead of as a first line, we think about it as a last line. And if we think about, the market, like market scope data, it's like 15% of all LASIK patients are co-managed by optometrists. Yet optometrists do like what, 90% of primary eye care, somewhere between 82 to 90%, let's say 90%. And and I think that sometimes, when I first came to San Antonio, some of the doctors were like, Bobby, I just don't want to send for LASIK. They're really honest, and I really appreciate that. They're like, I just like if I send for LASIK and the patient gets LASIK, I'm going to lose that patient. And the answer is like we know that optometry is already losing patients because we're seeing most of the patients, yet only co-managing 15%. So what happens is patients, have their eye exam. They're like, I think I want to get LASIK, but I don't want to ring it up to my optometrist. So let me just go into Google, type in like LASIK San Antonio, and then that's where I'm going. So I think, we wrote this article in Review of Optometry that said on average, optometrists as a whole, we lose that on about $565 million in co-management of LASIK. So it's like, how can we like stop losing these patients? How can these patients come in? Miss Jones, you here for a LASIK consult, cataract, are you here today for glasses, contacts, or to learn more about LASIK? Well, and you just at least starts the conversation so they come to you when they're interested in surgery. And times have changed, right? We're not in this like 1999 Summit Apex laser. What's the chance of you having 2020 in 1999? 50%. Like, isn't that crazy? People paid money for a 50-50 shot at 2020. I just think that's so crazy. And I think if you look at now, I think a little bit of what happens with LASIK is LASIK has been so jaded by dry eye and skewed towards dry eye. We know we have dry eye after LASIK. If you look at what's in the literature, we see that most of the time it comes back to baseline. But even if I still say that out loud, many people are like, oh, no, I've seen a lot of LASIK patients who have dry eye. And I would just tell you that working and we'll talk more about this at the end, but I've only worked in a surgical setting. Like I've never written, as an optometrist, I've never written a glasses or contact lens prescription in my life. So like, think it's just to acknowledge that. Now, second thing is if you look at most patients who come in for a LASIK consult, like 1 month, I was like, I'm tracking this. It was like 65% of patients who came in for a LASIK consult came in because of dryness in contact lenses. So interesting. It's like, okay, well, that means we're dealing with the dry eye patient population. And so the question is like, okay, if we're considering LASIK on a dry eye patient population, like, well, who really should be getting LASIK? Like, I know, sure, you go to some surgeons and they just do LASIK on everybody, but like, what does the data show? Like, what can we expect with LASIK? Like, let's just hear it from the patient. Like, let's not be skewed by any doctor, like in research, like whatever they're getting. Let's just see what the patient says. So if you look at the patient reported outcomes, there's plenty of studies. You had some of the research that looked at the FDA submitted data on a few of the recent, I mean, they've been actually out for a while, lasers. And then you have a longer term study. But if you look at, like, for example, the Wavelight topo guided study, you see that, glare and halo used to be a big thing, you were concerned with. But if you look at actually like baseline compared to afterwards, like more patients actually had no problems driving at night after LASIK. And so it's like now that we can correct spherical aberrations, now that we can measure the cornea ahead of time, like we just have better like nighttime vision. It doesn't mean you're not going to have any, right? Because why? Well, because patients are like you can get glare halo with whether you have glasses, contacts, or halos. I love this study that was done with regards to the military, active duty, and then civilians, which looked at dryness because that's a big thing. It's like I don't know. I left residency thinking the surgery that causes the most amount of dryness is LASIK. But if you actually look, there was an over 10,000. I mean, one of the takeaways you could take away from tonight is over 10,000 patients included in the Schauhorn study looking at optical express. And what they found was PRK causes the most amount of dryness. It's like, oh gosh, okay, PRK causes the most amount of dryness. Probably then, in my opinion, it's like LASIK, SMILE, then ICL. So, but in the patient reported outcomes with LASIK, so this is LASIK study, what you see is that at 6 months, more patients after LASIK had less dryness. You're like, what? How does that even make sense? And I think that what's happening is you see a lot of like contact lens associated dryness. So if a patient has dryness, they come in for a LASIK consult. one of the questions I ask them is without contacts, what is your dryness like? And if they're like, oh, I don't have any, I would call that contact lens associated dry eye. And those patients can get surgery, whether it be LASIK or SMILE or ICL or PRK. Now, for the patients who have dryness with contacts and without contacts, like those are the people that we got to be careful with. Those are the patients that we got to treat ahead of time. But for me, it was like the prow was like more reassuring in that, okay, you know what, these patients who are coming in with contact lens dryness, 65% of the patients we're seeing at LASIK consult, we got to dig into that. But it is safe to do LASIK. And in fact, we lectured at the Academy of Optometry in Orlando, and Mike Shumsky, he was like, LASIK treats dryness. And I'm like, okay, I don't know that we would go there. But it does. Like you see patients getting better, from 49% to 73%. That's a good margin. So there are patients, right, 3 times more likely for your dryness to get better than for it to get worse, but there still are patients who get worse. And so we got to be able to set the expectations with our patients. Now, this was done by Frank Price's group, and I love this study. This is 1,800 subjects that either continued wearing contacts, wore contacts, then had LASIK, or wore glasses and then had LASIK. And what you see here is if you look at the amount of dryness after LASIK compared to contacts in the group that had contacts, it's like the group that had LASIK actually had less dryness than the group that continued in contact lenses. So I'm not saying contacts are awful. I'm not saying LASIK is awful. I'm just saying that there are patients who have LASIK who can have LASIK or maybe told maybe not to get LASIK, who maybe we should consider LASIK because it actually might help their dryness. And again, like the difficulty at driving at night, sure, we want to set expectations, but these patients do well driving at night, especially once we can correct their vision closer to the nodal point. In this study with 1,800 subjects, you saw that 97% of people believed that LASIK worked better than their contact lenses. So I think that just like we got to just capture these patients and people who are interested in it. Let's talk to them. Let's set the expectation. Let's be involved in their patient care. Now, if you have somebody who like, man, you're really worried about dryness, or everybody's worried about the F word in LASIK, which is the flap, and they're like, oh man, we had one of our T-ball coaches recently say like, man, Bobby, I don't know if I can get LASIK. I'm a T-ball coach, I'm real active, I'm hitting the balls and talking with these kids. Like, what if they poke me in the eye? Like, I just don't think I can get LASIK. Right. So it's like this fear of the flap. For patients who are really worried about that, now we have Smile. So the one that's approved in the United States is Smile. There's other companies that are coming out with it, and I'm not going to touch too much on Smile because our next talk, I think that's next month, Dr. Cunningham is going to be talking about Smile. But with Smile, what you're doing is think about you're taking like a frisbee with a small opening, and then you're just sliding that frisbee out. So these patients have just like one little small, almost think about it. It's not necessarily, it's like a smiley face just on the top, so kind of like a frown face, right? So I guess if you look at it upside down, it's a smile, but it's a small little opening, and that small little opening uh, can be helpful. So, for example, somebody who came in who is, and if you think about like, well, who's the candidate for Smile? Just think about generally, if you're a candidate for LASIK, you're a candidate for Smile, and there's some nuances there, but like the numbers that I think about for LASIK, I think of the acronym HAM, HAM, and I think of like for hyperopia, I think of 4 diopters, astigmatism 6, and myopia 10, even though we don't like to go to 10, but 4 plus 6 equals 10. So H is 4, hyperopia 4, A, astigmatism 6 diopters. So if you had a plano -6 and they don't have keratoconus, you could definitely do surgery. You could consider surgery. And M, myopia up to -10. Smile is not approved in the US yet for hyperopia, has some astigmatism correction, not as much, but can go just as high on the myopia side or almost as high. Somebody's going to say, well, one study, LASIK is FDA approved for -14. Sure. Okay. But we don't like to do that. So Smile helpful. You have an MMA fighter who comes in who's like, I want to get my surgery corrected. We had this gentleman come in. I guess it's been now like 4 years ago. MMA changed their policy where when you're fighting, you actually can't perform an MMA fight with contact lenses in. And so this gentleman was like undefeated his first 7 fights. They changed that rule. He's a -5 myope. And he's like, I need to get surgery because ever since I stopped wearing contact lenses and I've been fighting, my past 4 fights I've lost. Yeah, of course, you can't see. So if you're like worried about like, well, what if he gets hit and like he has a okay, let's potentially consider Smile. So did Smile? He did great. And what happened if you've been like following Smile? The first version of Smile, people were undercorrected. Then the second version, they were like slow to heal. But now with low energy Smile, and if you have a nomogram, overall these patients they recover quicker. I still think LASIK has a slight edge, but Smile overall these patients do really well. And it's like the thought on Smile is that you preserve more of the anterior stroma. So the thought is that maybe these patients have less dryness, maybe they have a stronger cornea, and so maybe these patients are and I would say that, that is true. Like with Smile, these patients have a quicker like physical recovery. It's almost like the next day, many times patients like they're like it kind of just feels the same as it did yesterday, or the day before. So if you look at what's in the literature, the dryness is still up for debate, but I do think that we see like both of them, dryness, you get hit with the dryness, you come back to your baseline level, but Smile, they just recover quicker. And so I think that these what we see is like more and more clinics adopting Smile once you figure out the nomogram and once you figure out the technique. And now I think they'll probably talk about this next month is you have the newest laser that Zeiss has is the Vision Max 800 with like a Lamborghini style laser. It's pretty cool. And it can perform Smile in 8 seconds. Like it's just crazy. Your treatment for myopia can be done in 8 seconds per eye. And then you have to dissect the lenticule. But I think we're going to see more and more adoption of Smile. It definitely has been adopted outside the United States. Like in some countries, it's being done more than LASIK. And just like with LASIK, how we're seeing these patients and checking to make sure no inflammation, infection, checking on the dryness, they're on steroids, antibiotic for about a week. Same thing we're doing postoperatively. And I think we're going to continue to see more and more of these patients in our clinic. And so I think we got to be ready to co-manage these patients. All right. Let me see if there's any questions. Here, hold on, where did it go? Okay, oh, here it is. Ah, oh yeah. The one study that talked about PRK actually having more dryness than LASIK was done by Dr. Schauhorn. So if you just type into Google like PRK more dryness Schauhorn, Schallhorn, it was a big retrospective study done. I think it was in the UK with the Optical Express group, so you can check that out. All right. So our next case, this was a gentleman who came in and had dryness and had some dryness. But overall, like just didn't want to wear glasses or contacts. You see here with like a low prescription here, minus 250, minus 125, 174. The thing was, he was he had some weight on him. It was 425 pounds. And what was happening is, as we were thinking like LASIK, PRK, or Smile, the beds only support so much weight. So the question was like, are we going to be able to get him to the right docking position for LASIK, PRK, or Smile? And the answer was basically it was over the weight limit for both beds. So if you look here at his scans, like his scans look great. I mean, he has some astigmatism, cornea's 554. By the way, if we got anybody here who's like, hey, how do you read these scans? Or like, what are the things that you look out for? I learned this at OCCRS back in 2016, 2017. Bill Tulo kind of gave a recap at the time of all of the ectasia cases after LASIK, which, by the way, when I don't know, when I was a student, I thought ectasia happened 1 in 100, yeah, 1 in 100, maybe 1 in 20. I don't know. But they basically published that ectasia happens 1 in 9,500 cases. It's like, gosh, okay, how do we find these 1 in 9,000 eyes? And what they found was if a patient was not correctable to 20/20, alarms, sirens, like, okay, is there something else going on? And second was inferior steepening. So the IS ratio was greater than 1.5. So if you look at this number here in the 3 to 5 ring, you look here at this 46.1, you compare it to the 46.2, and if this inferior number is greater than 1.5, that would be a sign that would say, hey, that's a risk factor. So those are the things that I look for here is IS ratio greater than 1.5. Of course, if you have inferior steepening and posterior float, when you see a posterior float, remember in keratoconus, these eyes bulge not only on the front, but they bulge on the back. And so you have any posterior float of like plus 12 or plus 15 or more, we start to think about potentially keratoconus because that's what we're trying to think like these patients who are having ectasia instead of it being like post-LASIK ectasia, it's more like they had ectasia to start, and we just got to find it before we do laser on these patients who have ectasia. You look at the left eye looks good. So like, what do? We tell this patient like we can't do anything, or do we have another option? And now, we have LASIK, we have Smile, we have PRK, but we basically couldn't do that in this patient. So what we did for him was ICL. And ICL stands for the implantable Collamer lens. The ICL can correct anywhere from -3 to -16 diopters. It's approved for -16 to -20. And it can be done for anybody who has goofy corneas, thin corneas. And it works well. And there, I think what happened is when ICLs first came out, people were like, "Oh my gosh, how does it compare to LASIK?" But there have been plenty of studies, even looking at like the military warfighters and looking at their like nighttime vision and showing that LASIK and ICL improved their vision compared to baseline, but ICL improved their vision more. And I think the reason for that is because when you correct the vision closer to the nodal point, you have less magnification. And the EVO ICL in the clinical trial, 52.3% of patients gained one line of vision. 52.3% of patients gained one line of vision. And what was the average manifest in that clinical trial? -4.6. So -4 point, let's call it 7.5 myope. Half of those patients gained one line of vision. Again, because we're correcting the vision close to the nodal point. Now, ICLs used to be more of like an involved process. You have to do iridotomies. Now the EVO ICL has fenestrations through them. And so that allows aqueous to go from the front to the middle, out the trabecular meshwork. And so now you don't have to do iridotomy. So you're able to place this lens just beneath the surface of the eye in the sulcus. So behind the iris, and it vaults forward over the crystalline lens. Um, let's see. Do we want to show you a video real quick? Let's see. Is this going to play? Just if you haven't seen the video, this is the old version of the ICL. Let's see. But the ICL just basically unfolds like this. This is the one that wasn't the Evo. This procedure takes like it's pretty quick, like 3 minutes an eye. So also if you have like a really nervous patient, you want to give them some IV anesthesia or some like better anesthesia, like you could consider ICL for those patients if they're not going to be still during docking the laser. But these patients, like there is more, ICL is really growing. Smile's growing, ICL is growing, and we got to be able to see these patients afterwards. These patients have an antibiotic steroid for about a week. We're looking at the anterior chamber to make sure the anterior chamber, the inflammation's improving. We're checking that eye pressure because again, we use visco at the time of surgery. So just like in a 1-day cataract post-op, in an ICL post-op, the pressure could be high because of the visco. And then we're looking at the vault. We want to look at how much is the vault vaulting over the crystalline lens. So just like with scleral lenses, you can use a slit lamp beam to look at what's the vault of the scleral over the cornea. But with ICLs, you can look at anterior segment OCT just like you can do with scleral lenses. So you can either look at the slit lamp or you can do anterior segment OCT to look at the vault. Now, the previous version of ICLs, we were like more worried, like, oh gosh, man, we gotta make sure the vault's like just right, like Goldilocks, not too big, not too small. It's got to be just right. Now with Evo ICL, you can have a smaller vault and there's less incidence of cataract. Like there's less visually significant cataracts. Uh, some people would say like the risk of cataract is virtually zero. And really during surgery, if you have a good surgery, you're not touching the lens. Now the aqueous is flowing through and it's almost like the ICL is like even in low vaults because aqueous is going through, you're getting the nutrients to the lens and it's almost hovering above the crystalline lens like a hoverboard. And so these patients, here's a vault you're looking at the vault here compared to the cornea here, and it's about 100% of the central corneal thickness. Here's an ICL. And so you're going to see these, and you're going to be like, gosh, what's going on? Why do they have a hole in the middle? Well, that's allowed the aqueous to flow through. And like they did studies, it's not like visually significant during the day. The aberrations is great. At night, these patients do on off-centered lights, they see this like ring dysphotopsia, but that gets better again. Neuroadaptation's a thing. So these patients with ICL, it's great. I mean, of all the procedures, like this is the one, like if somebody has dryness, I think this procedure causes the least amount of dryness of them all. And you'll see that these patients who are high myopes, like you want to make sure they have space, you want to make sure they have an adequate anterior chamber depth. It's FDA approved for greater than 3 millimeters of the anterior chamber depth. But you'll see these patients like do really well. Like the vision at the 1 day is what they have at the 1 month. So it's like LASIK-like recovery. So if you have a goofy cornea and you're like, man, maybe we should do PRK. Instead of doing PRK, you can do ICL. You can do ICL and you have a quicker visual recovery without pain. And so considering ICL for these patients is really is I think we're seeing a growing more and more market of more and more patients choosing ICL. And again, because you get that vision improvement, In the FDA clinical study for toric ICL, 75% of patients gained one line of vision. And so I think that we're seeing, again, here in the EVO patients, 52.3% of patients. Okay, I'll be there in a second. Okay. Um, gained one line of vision. And again, with that vision being minus 4.6. So we have more and more options, for example, for these patients who have goofy corneas, for example, outside the United States, this would be off label. But in our experience, we've had success with these patients who have goofy corneas and being able to correct their vision. So I'll pause there for, let's see if there's any questions here. No, I think we're doing good there. So, I think with regards to, let me come back here before we come to this case is, I think with ICL, the benefit there is you have the ability, a lot of these patients who you think have like amblyopia, you're able to put the lens just beneath the surface of the eye. All of a sudden now they can see 20/20. And so you're like, oh, I thought they had amblyopia, but really it was just minification. The other thing is, I would say for the patients who have, we talked about these contact lens associated dry eye. If you want to be like super sure, like the ICL is nice. Many patients too, like there's some people who are just like, just like worst case scenario thinkers. The fact that it's reversible is great too, because you could put the lens in. Somebody doesn't like it. Okay, you just take it out. We had one patient who, what was the reason why they didn't like it? I don't remember the exact reason why, but they were like, man, out of thousands, right? One was like, I just want to take it out. They took their contact lens, they took the ICL out, put their contact lens on, and now they're still 2015 in their contact lenses. You could always come back and do LASIK too as well. So I think with, in these patients who, have goofy corneas, have really extreme prescriptions, right? This goes up to spherical equivalent of minus 16. So you could have a patient who's minus 14 myopia with 4 sil, and you could still correct their vision. I mean, this is a game changer for these patients, just being able to wake up and see. And again, I think the dryness, that's a big, big patient population group that we're using ICLs on when they come in and they have and they have uh and they have and when they have dryness, and you're not sure, the ICL works great. Now, quick question that came through the chat is, what happens when an ICL patient needs cataract? Like, that's the best part about ICL, maybe one of the best parts, is that you take the scans for these patients who need cataract surgery, and you can now take the ICL out. They haven't had any ablation in their cornea, so you have the ability to take it out. You can do phaco, and then you can put whatever lens you want in. The ICL is a very soft lens. If you ever have the opportunity at a wet lab to feel it, I would encourage you to feel it. It's very, very soft. And so it's really easy to remove um, most of the time, right? Granted, there's always curveball cases out there. But when somebody has cataract surgery, you just take it out. They have no ablation to their cornea, so you can put whatever lens in. So especially in these high myopes, minus 6, minus 7, minus 8, minus 9, minus 10 myope, like consider doing an ICL in these patients because it keeps all their options open for the future when you're considering that. So I think that, we've talked about this earlier. When we're talking about myopes, we have LASIK, we have SMILE, we have PRK, we have ICL. Now, as we're getting into our presbyopia age, we can use any of these strategies to do blended vision. But as we get to become, in our above 50 and hyperopes, like for sure, like this just becomes like cataract surgery, refractive lens exchange, being able to do a multifocal, being able to do blended vision is great. Another question that came through is, are patients who want to be military pilots better suited for SMILE or ICL procedure? It's really interesting to see what's happening in the military. Like the refractive surgery scope is changing a lot. And I think there have been in the past 2 years some patients who have gotten waivers with regards to military to become pilots. But with regards to these patients, it's up to the military, and I would tell them to talk with their recruiter. But you are seeing more and more ICL being done in the military. So let's see here. So I think overall, I think we got to be ready to handle these patients. We got to be able to catch these patients when they're in our chair. And I think, we're just seeing the role of the OD is going to continue to get bigger and bigger and bigger. So we got to be ready for these patients. So I will stop sharing. And Dr. Major, I'll let you come on here. And I'm probably just going to mute myself for a second and close my door real quick as the kids came in. And then I'll answer some questions.
Excellent presentation, Dr. Science. Go ahead, close your door, and then we do have some questions that came through the Q&A that I will fire at you here in just a minute.
Okay, I'm back.
Let's start with ICL. So there was a question, if someone has an ICL, is it safe to dilate them?
Yeah, it's a great question. The only patients that you don't want to dilate are patients who have iris fixated lenses. So those would be like surgeries that have been done like forever ago. If somebody has ICL, it's in the sulcus. So you can dilate these patients, you can make their pupil smaller. It's not going to impact their vision, and you can look at their retina. And again, these are high myopes too most of the time. These are myopes. So yeah, we definitely want to look at their retina, but you're not going to like hurt anything or change anything by dilating these patients.
Next question, if there's an IOP spike after ICL implantation on day one, do you ever burp the visco out of the incision?
Absolutely. Yeah. So I usually say, if a 1 day post-op, usually you see them about an hour afterwards, 4 hours after, somewhere in there early on, just to check, and you check it the 1 day. But you treat them just like cataract surgery. If the pressure is really high, you burp them. If the pressure is like moderately high, you can just use drops to get over the visco as getting absorbed. Now, if the vault is really too high and it's causing the angle to close, okay, well, you're gonna have to swap out that ICL for a smaller sized ICL.
Great, thank you. Are ICL for hyperopia a thing yet, or plus with HICL?
Yeah, ICL is a thing for hyperopia, but you have to remember that ICL for hyperopia, ICL goes in the sulcus, and you have to have space. And hyperopes usually have a small eye. But if you have the unicorn of a patient who has a hyperope with a bigger anterior chamber depth, you can send them to our friends in Canada or Tijuana in Mexico. And there are hyperopic ICLs available outside the United States. I think it'll be a while before they're approved inside the United States. Um, but yeah, they're definitely available outside the United States. And if you guys, I'll put my email, the bobby@imission.com email back up in a little bit. You can email me if you need to know like any specific recommendations of like where you would send.
What percentage of patients need PRK after SMILE?
I mean, if you look at enhancement rates with like anything, the question is like, what's the enhancement rate overall with this is called laser vision correction? Because once you dial in the nomogram with Smile, like I would say that the enhancement rate is pretty similar to LASIK, generally speaking. There have definitely been some studies that have shown that patients with SMILE have lower enhancement rates. Dan Reinstein had a study showing that it actually had a lower enhancement rate. But I'd say overall, like I tell patients, like on average, ballpark numbers. If anybody wants to get really nerdy afterwards with this, I'm happy to do so. But I just tell simplicity for patients, like that's about like 3% chance that you might need a touch up. And with Smile, just FYI, on labels you can do a PRK enhancement, but if you know how to figure out the software, you can actually take that Smile, that little small opening, make it bigger, a LASIK flap, and you can actually do LASIK on top of Smile for an enhancement if you want somebody to have a quicker visual recovery.
Um, Excellent. There was a question about what's the approximate cost for ICL and toric ICL nowadays?
Yeah, I would just generally, let me ballpark it. I would just normally say that ICL is normally somewhere between $2,000 to $4,000 more than a laser vision correction procedure.
And then a somewhat specific question, what would you recommend for a patient who had LASIK 25 years ago, was -11 pre-surgery, and now has cataract?
And is there anything wrong with their retina, did you say?
I would assume
Hmm.
no.
I would do light adjustable lens all day in that patient. If
Um,
they're
uh, I'm sorry, go ahead.
No, I just like light adjustable lens because, if you have that cornea, you're not really sure where they're going to land up. As long as their ablation is centered, I like light adjustable lens because if you end up farsighted or nearsighted, you can really take that patient to where they really need to. And if there's a chance that they're still like nearsighted right now and they love their nearsightedness, it's really great that we have the ability to kind of give them a range of vision.
That's a great point. Another somewhat specific scenario, what type of lens would be better with a patient who has one eye that's 20/20 due to epiretinal membrane in the dominant eye and is moderately myopic?
And are they happy? I mean, that would be my next question. Like, were they happy with that or are they not happy with that? If somebody has a little bit of a blended vision and they're happy, like, great, keep them in blended vision. And if they want distance in both eyes, great, give them distance. And if you're not sure, then do a light adjustable lens because then afterwards you get to let them test drive their vision and they get to like figure out afterwards like which way they want to go.
Great point. And last question, with the Apthera IOL, is it difficult to evaluate the peripheral retina, like say, or treat retinal holes if you need to?
Yeah, the Apthera has the mask, it doesn't go all the way out. So when you dilate the retina, as long as somebody dilates well, like if they dilate well, you're able to get outside of the mask and look through the optic like it's almost like a monofocal IOL. And usually, when tears are happening, it's out in the periphery, so you're able to look through that on the outside. But if you take like an Optomap, you'll be like, and you don't know they have that, you'll be in for a little bit of a shock when you're looking at it. You're like, oh my gosh, what's happening here?
Great. Well, thank you so much. That's all the questions that we have here. I know there's a bunch of thank yous coming through the chat box here. I want to thank you as well, Dr. Science, for that excellent presentation, and Zeiss for sponsoring this CE here this evening.